To help you get ready for our selective class, I've created this quick review. The three most important steps to diagnose a urinary tract infection are culture, culture, culture. But not all positive cultures equal urinary tract infection. Contamination and colonization is associated with more than one species in low numbers of organisms. So how do you know when you have a true infection? Well, true infections usually have high numbers of bacteria. The typical strains, E. coli, Staph, Enterococcus, Proteus, Klebsiella, usually they only have one strain. So those are the things you need to remember. Of course, urine cytology, when it's filled with white blood cells, may also help determine that you have a true infection. Why classify UTIs? Well, the reason why we do that is to determine the need for therapy and how to administer it. The simplest way to classify a urinary tract infection is subclinical and clinical. Subclinical infections, it's obvious, occur without clinical signs. Clinical infections are associated with dysuria when they involve the bladder, and pain and fever if they involve the kidneys. We further divide them into sporadic and recurrent infections. Sporadic infections are infections without an identifiable cause and generally respond quickly and completely to short courses of antibiotics. These types of infections are common in young female dogs. Recurrent infections recur quickly after stopping antibiotic therapy or persist despite our therapy. Recurrent infections are further divided into reinfections and relapses. Why do we make this distinction? It's because it determines your next steps. If you have a reinfection, it means that your antibiotics were effective. Giving another antibiotic course is not going to solve the problem. Your goal is to look for structural and functional deficiencies in the urinary system, things like stones or a hooded vulva or cancer, or the patient is immune compromised. When you have a relapse, it means that your antibiotics were not effective. So choosing a better antibiotic strategy would improve your success. It may mean you gave the wrong antibiotic, didn't give it long enough, or didn't give an antibiotic that penetrates deep within the tissue. It could also mean that you didn't remove the nidus of the infection. When we treat, what are our goals? Well, number one, we want to keep the patient comfortable and alive, which is great. That's why we give empirical antimicrobics sometimes, especially when they're needed. The other thing we want to do is eliminate the bacteria, allow the urinary tract and its defense mechanism sufficient time to recover. We also want to allow sufficient time for the underlying disease to recover. So those are the reasons why we give antibiotics. But one really important one is we want to minimize adverse events. We want to minimize antibiotic resistance or any organ damage if we give the wrong antibiotic. Treatment. To treat or not to treat? Oh boy, that's a big clinical question, especially with antibiotic stewardship. Well, what you need to know is that there are many bacteria in the body. Some are beneficial, and we don't want to hurt them. So if they're not causing any harm, we leave them alone. But the important thing to realize is we coexist with bacteria, and that coexistence is dynamic. Knowing when to treat is not completely known. But here's a guideline that you can use. If by withholding treatment the consequences are pretty low, don't. But if the consequences may be high, you may want to treat. So in a very debilitated patient with previous kidney infection, I may go ahead and treat that subclinical bacteriuria. Well, the other arm is easy. When they have clinical disease, we want them to be comfortable, right? So we're going to go ahead and treat. Next, let's talk about how to select an antibiotic to treat your UTI. I use 4 principles. These 4 factors will help you select the best antimicrobic. The first one is the in vitro antibiotic effectiveness. Culture and susceptibility testing is the best way for you to predict your antibiotic effectiveness in your patient. The next thing you want to do is look at where the location of the infection is. Many antibiotics reach high concentrations in the urine, but not always high concentrations inside the tissue. Did you know that when you submit your culture, you can specify if you want a urine or a tissue MIC? So select your culture tests based on the bacterial location. In general, choose water-soluble antimicrobics for infections in the bladder and lipid-soluble antimicrobics for infections in the kidney. The next thing I want you to consider is the virulence of the bacteria. Proteus, urease-producing staph, and Corynebacterium are quite destructive. For example, Proteus is usually susceptible to most antimicrobics, but in my experience, you will not effectively clear it without using high doses or antibiotics that have better tissue penetration, like those that are lipid-soluble, like a fluoroquinolone or trimethoprim sulfur. And lastly, we can include the inhibitory quotient. I don't use this often, but it's a wonderful strategy if you have a difficult infection. What you're really doing is comparing the maximal concentration the antibiotic reaches in the tissue based on the MIC. Let me give you a quick example. You can see that enrofloxacin and marbofloxacin both reach concentrations in the kidney. What we're going to do is compare that to our MIC results. It's good that we use the same one, 0.25. So we know that we can divide that into our tissue concentration. For Baytril, we'll get 7.8 times the MIC, but for Xenoquin, we're going to get 28 times the MIC. If you really had a difficult bacteria to eradicate, you're going to use marbofloxacin to get that much higher concentration. How long to give antimicrobics? Well, it's not set in stone, but let me tell you what we know. Short-term antimicrobics are effective, and unfortunately, resistance occurs when you give antibiotics for a very long period of time. When I'm thinking about antibiotic duration, I base it on the disease, but I give the shortest duration necessary to clear it. For a sporadic bladder infection, 3 to 5 days should be efficient. When I have recurrent infections, I may give them a little bit longer, 5 to 10 days. Kidney infections and prostatic infections, 1 to 2 weeks. Infection-induced struvite stones, often up to about 2 months, because that's how long it's going to take to dissolve those stones. And if I really don't understand the infection very well, or the location or the cause, I'm just going to give it that 3 to 5 days. And if need to be given longer, I'll do that later. When to perform my follow-up cultures. It's also based on disease. For sporadic cystitis, I'm not going to do a follow-up culture at all because I'm not going to treat it, of course, unless there's recurrence of clinical signs, and that's when I'm going to culture. But if I have persistence of clinical signs, I'm going to do it 3 days after starting my antimicrobics, actually while the dog or cat is receiving the antimicrobics, because I want to know why this is occurring. If I have recurrence of clinical signs, it's going to be at the time of recurrent clinical signs. If I have a high-risk, life-threatening disease like pyelonephritis or Corynebacterium, I'm going to give it 3 to 5 days after starting my antibiotics and while my antibiotics are being given, because I want to know whether or not my antibiotics are effective. And that's the best way for me to know is to test it in the dog or cat that I'm actually administering the drug to. If I'm dissolving infection-induced struvite stones, it's going to be 4 to 6 weeks into therapy to make sure that I haven't developed resistance and that my antibiotic is effective and the owners can effectively give it. If I want a sure effective antibiotic response to antibiotics such as eradication, that means that I've given my antibiotics and I want to know if the antibiotics completely cleared the infection, I'm going to give it about 7 to 14 days after stopping my antibiotic therapy. Great, you've had a short course in how we treat and diagnose urinary tract infections. Let's go through a quick summary. Diagnosis and treatment. True infections mean high numbers, the usual suspects, in a single organism. Reinfections, which means a different bacterial species, indicate effective antibiotic treatment, but poor correction of the underlying risk factors. You need to do some more diagnostics to eliminate those risk factors. If I have a relapse, it means I have ineffective antibiotic treatment. I need to also remove the underlying risk factor, but I may need to give a lipid-soluble antimicrobic or give it longer. The most effective treatment plans take into account susceptibility, location, and virulence of your organism. That's really what I showed you earlier today. Most infections are effectively treated with 3 to 5 days of a susceptible antimicrobic administered at a high dose. So that's what you're going to give most of the time. Well, there's your quick 10-minute review. Remember that I also have a quiz for you to take. Oh, don't scrunch up your mouth because I gave a quiz. It shouldn't be that difficult. And the good news is you'll have 3 tries. Good luck, and I can't wait till I see you in class.